This case just came to me, referred from one of my friends. So this case came to me, referred from one of my colleagues. It was just an intumescent cataract with high tension. He saw that the case, we can't just stay and wait and see. Do you find any, you can guess that there is any abnormalities in this intumescent cataract? What do you think? I have a very shallow anterior chamber and very high intraocular pressure. I'm going to have a cataract to do phaco for this case. Do you have any comment about this case?
I think the posterior capsule in this case might be compromised with the traumatic cataract because you can see around it darker shadow at the back of the lens.
Yes, thank you. Okay, so I start doing just to debulk the pictures because I have no space for just introducing my phaco. I just do vitrectomy, just a dry cutting and then closing I don't have a 25 gauge, but I use 20 gauge. Then I close the sclerotomy and so I can tell you what's about this case. This case, if you can just look around, you can find a very little glistening in the anterior chamber. This is an ICL in the anterior chamber. That's why, because the doctor who saw the case before, he saw that he has just a posterior cortical cataract, posterior subcapsular cataract. Then he tried to do a YAG laser for this case, and this is what happened. That the anterior capsule just opened, and he told me that the last surgeon has left a lot of cortical matter. We have to remove it. That's why I tried to do this lensectomy, and so vitrectomy, just dry vitrectomy. Then I tried to get this lens outside. Then I tried to cut the lens. Maybe my friend Dr. Asaf just saw this before, and I told you that phakic IOL or the ICL, you can just remove it with just very small, you can take it out even if you don't cut it, but I cut it this time. Then it can go out like this. It's very simple. Then I remove it. Then I do just infusion. The case was just needs an IA, and this is the case. And I do the IA. I was looking for the flap motility sign to be sure that there is no rupture posterior capsule, because I was depending on the flattering and the everted flap only to be sure that there is no posterior capsule rupture, or there is no extension will happen if I implant the IOL. Then I implant my IOL and try to just making with a minimal aspiration to just doing some sort of cleaning of the posterior capsule and an implanted IOL. And the problem now is I'm having just a wide pupil. What do you think in doing in such case with this wide pupil? I just try to...
This patient had high IOP and that's syndrome is dilated. I will go on for the pupilloplasty.
Pupilloplasty, yes, okay. I try to do just minimal aspiration to just take the pupil in such way, and this pupilloplasty is the second choice. I agree with that. Thank you very much.
Thank you very much, Professor Ahmed. You are fortunate that you don't have rupture of the posterior capsule. You find at the end of the surgery that the posterior capsule was intact. So suppose that you have a suspicion that the posterior capsule is broken, what would you do differently in this case?
Maybe in this case, I don't have a good nexus. Maybe it depends on the side of the rupture posterior capsule. If it is, if it is with this trauma, I think it's, I go for the Yemeni technique for implanting the side.
Any question from the panel? Okay. One quick question.
I think the thing we often miss in assessing white cataracts is not to do a UBM before surgery. It's actually a UBM. Because unusual white cataracts have lots of secrets inside.
I agree.
It's driving.
That's right, yeah, you can give a good idea about the posterior
So
capsule.
really a good piece of advice if you have a unilateral white cataract, no clear history of trauma. Obviously, we have a trauma there is a no clear history of road traffic accident with children, then UBM is really is a must in assessing the case. When you see my case, which is coming after you, I did the same mistake.
You're guessing the next one. The next one.